Everyone, thank you for having me here. Like Dr. Desai said, we're going to switch topics a little bit and talk about stroke in children. And I will say it does happen, but it's going to be very different than what we've learned with regards to stroke in adult. I have no disclosures. So I think the best way to talk about it is to talk about it through a case that I actually saw when I was in residency. This is a 4-year-old previously healthy boy who came in. He had acute onset headache, left-sided facial droop, and weakness. So on exam, his temperature was good, 37.3, but he was febrile at some point to 101 reportedly. Blood pressure was 95/58, which is normal. Heart rate 117, respiratory rate 22. On his exam, it was noted he was awake. He said head when he was asked about pain. He gave thumbs up on his right hand to command. He had a right gaze preference, a left upper motor neuron facial weakness, and a moderate left hemiparesis with anti-gravity movement of his arm and leg to stimulants. Otherwise, he also had some neglect as well. So in seeing this patient, this is obviously very concerning, and he's acting just like a stroke. And the question is, in an adult, we do a non-con head CT, but here it's a little different. So our pediatric stroke protocol was activated, and contrary to adults, our pediatric stroke protocol lists MRI, MRA in anyone less than 13 years old. And if over 13, we do a CT, CTA perfusion. Obviously, though, in centers that do not have 24/7 MRI, and a lot of times these cases come in at 2 in the morning, a CT should be done. But in all honesty, if an MRI is available, that's what I would favor, because at some point we're going to have to get an MRI with this patient. Just because with the non-con head CT doesn't necessarily, just because it's normal, doesn't necessarily mean something else isn't going on with the patient. So with this patient, this is what his MRI showed. You see an extensive infarct in the pattern consistent with the right ICA terminus occlusion, involving the entirety of the right MCA territory, including the basal ganglia, ventral right thalamus, and the distribution of the right PCOM. The MRA showed that obviously something is missing right here compared to this side, which shows absence of flow through the right internal carotid artery. So this is a pretty significant stroke, and why would it happen in a previously healthy 4-year-old? Normally we see this in that 75-year-old patient with poorly controlled AFib, hypertension, hyperlipidemia, diabetes, etc. So a little bit about childhood stroke. The first thing to know is that it's described as greater than 28 days of life. This is in contrast to perinatal or neonatal stroke, which happens in under 28-day-old babies or newborn babies. And this is an important distinction because the etiologies behind those are completely different, such as HIE. There are about 3,000 reported child strokes that have been reported in the United States a year, and that includes ischemic and hemorrhagic. The breakdown is different, though, with adults having about 80% of the strokes that are ischemic, and in children about 50% of the strokes are ischemic, so it's pretty even. They can be embolic, thrombotic, or small vessel. After occlusion of the vessel, the most important thing is very similar to adults. It's time is brain. We want to save the tissue at risk. So obviously there's this irreversible injured core infarct, and then the larger number of brain tissue around it, which diminish blood flow that we want to try and save. The most frequent reported sign of ischemic stroke in children is focal neurologic deficits, such as hemiplegia, speech and language difficulties, vision changes, or ataxia. But other presentations also include altered mental status, headache, and seizures. Seizures are in particular important to take note of because they are more common in children than adults, presenting about 30% of first-time presentations of acute stroke, especially in those that are less than 6 years old. Similar to adults, the most frequent affected artery is the MCA. So this is the cause or the causes of ischemic stroke in children, and they're very different in comparison with adults. As you can see from the list, there's a large variety of etiologies that can cause stroke. Childhood strokes are often related to large vessel arteriopathies, which we'll talk more about later. Other common etiologies include cardiac as well as hematologic causes. There are also something specific called non-vascular strokes, and those are considered energy failure strokes where they're not in a distribution of vascular territories such as mitochondrial diseases such as MELAS or Sturge-Weber. However, in the International Pediatric Stroke Study, it's shown that about 10% of childhood ischemic stroke, we actually have no idea why it happened and cannot find a reason. So we can split underlying etiology simply. I kind of think about it in blood vessels and heart, just like adults. Childhood strokes are more often related to something called large vessel arteriopathies, and several approaches have been used to try and classify these types. So quickly, usually with childhood stroke, there's not one reason. It's very multifactorial. In most cases, it encompasses genetic, inflammatory, and environmental factors. So it's not as simple as we think. As we talked about, the most common is a focal cerebral arteriopathy. What that means is it accounts for about 45% of childhood strokes. It's defined as a unilateral stenosis and or irregularity of the large intracranial arteries of the anterior circulation. There's multiple different types. The first is the dissection type, which is typically seen in the setting of trauma. The second one is inflammatory type, and that's a little bit more vague, but it really presumes something like a focal vasculitis, such as a transient cerebral arteriopathy, Moyamoya, or following a VZV infection known as post-varicella arteriopathy, or it could be something genetic or syndromic. And then there's, of course, the unknown etiology, FCA. So I think we'll talk about these first. So a transient cerebral arteriopathy involves the junction of the distal internal carotid artery and its proximal branches, the MCA and the ACA. The clinical course is very stereotyped, so what it means is that you'll have a monophasic natural history characterized by a frequent early progression in clinical symptoms with a non-progression in about 6 to 12 months, and they're fairly slow. Some will have improvement after that, and others will have complete resolution in a very small amount. What's also to know is despite having this type of stroke early on, there's a very high one-year occurrence rate, ranging from about 25 patients will have another episode of this. The second one is something called Moyamoya. This is a disease that is much more progressive as compared to transient cerebral arteriopathy. This is a result of a formation of collaterals to compensate for all of the occlusions, and that's known as that puff of smoke. There's a bimodal age distribution, so more commonly seen 6 years old and then later on at 40 years old. And there's a high prevalence of TIA and silent infarction with these types of patients. In a cohort study they did of 54 children with Moyamoya, TIAs occurred about 70% of them and stroke in about 48% of them. And incidentally, imaging at the time of diagnosis actually shows evidence of silent strokes and infarcts in half of these patients. The treatment for these types is really dependent if they're having flow-related ischemia. So if they're completely asymptomatic, usually no treatment is advocated. However, if they're continuing to have multiple TIAs, multiple strokes, and progression of stenosis on their head imaging, medication is first line, and that would be things to increase the flow through your vessels. So aspirin, a high-salt diet, fludrocortisone, midodrine are going to be really important. In these types of patients, you want to avoid antihypertensives because the lower the flow, more likely you're going to get flow-related ischemia. In more severe cases where medication isn't doing its job, they have surgeries that can be done. The first is a direct bypass, which takes the superior temporal artery and the MCA and literally sews them together. Indirect ways are taking an indirect bypass, which is taking either the temporalis muscle or the temporal artery and just sticking it on the brain, and blood vessel and collaterals will grow in between those. There are also associations, again, between stroke and genetic disorders. So arteries are formed from 3 layers: the tunica intima, the media, and the adventitia. And the development of these blood vessels is a very complex process. And once you have mutations in various genes, this can affect blood vessel dynamics, making people predisposed to stroke. It affects brain, muscle, kidney, eyes, anything that's related to smooth muscle. Probably one of the more common ones is ACTA 2A, and what that is, it's an autosomal dominant syndrome that presents with subcortical white matter infarcts and straight bilateral internal carotid arteries. The sequelae is in smooth muscle dysfunction, so in those patients you're going to see dysfunction in their bladder, you're going to see pupil abnormalities as well as aortic arch. Another genetic mutation that you can see is in the COL4A1, which plays a role in angiogenesis and mutations linked to disease and vessel wall integrity. A very high-risk population in pediatrics that also develop stroke is sickle cell disease. About 11% of sickle cell disease children have a stroke by age of 20, and it's actually probably one of the biggest risk factors for developing stroke. They have a 200-fold increase. There was a randomized control study done in 1995 called STOP, looking at stroke prevention trial in sickle cell anemia. In that trial, what they did is they took children who had sickle cell and they started doing TCDs to measure the blood flow. And what they did is they tested to see if blood transfusions themselves would have effective for primary prevention in strokes in these types of patients. What this study showed was that there's a huge benefit from chronic red cell transfusion in reducing the risk of stroke in about 90% of patients. This study was actually so successful that it was actually halted before its scheduled closure on the advice of the study's Data and Safety Monitoring Board, because they felt that they just had to implement this change right away and stop with the study. Other etiology we can talk about is cardiac. So cardiac embolic strokes account for 30% of childhood stroke. They occur as a result of primary things: congenital heart disease, procedure-related events, or acquired heart disease. There's been an increased use of assisted mechanical heart devices, which has been improving the survival in these patients with heart disease, but also increasing the incidence of stroke. In children requiring assistive devices, the Berlin Heart X-Core VAD actually has the highest prevalence of stroke, about 28 to 34%, as long as ECMO, the Fontan, and cardiac caths. Other options include the endocarditis or acquired heart disease. So when you first see a patient as a child and you're concerned for stroke, the most common includes evaluation of the heart, radiographic screening of the vessels, thrombophilia testing, and inflammatory markers. So obviously basic labs will be first. MRI brain with diffusion-weighted imaging is preferred method because there are lots of mimics of strokes. Once diagnosis is confirmed, then you can go ahead and do an MRI brain and neck. Other options include EKG and echo with bubble that should be done. Vascular imaging, though, is probably the most important thing to understand the etiology of the stroke once it's confirmed. This is a list of the thrombophilia workup that you should do. One or more prothrombotic states have been found in about 25 to 55% of children with stroke, mainly factor V Leiden, prothrombin, as well as MTHFR. Though most believe that while a prothrombotic state represents a potential risk factor, it usually works in combination with other things rather than independently to cause these big strokes. Depending on presentation and imaging, workup can also include metabolic stuff to look for non-vascular strokes or inflammatory disease. A lumbar puncture can also evaluate inflammation and causative agents such as HSV, VZV, if there's a dissection, hypermobility. You could also think about genetic screening. And the next is, what do we do in these cases? So in adults, it's already been clearly shown that TBA is beneficial in adults when implemented in a discrete time window, which I suspect you guys have talked about already. But the question really is this something that's employable in children? There are a lot of challenges for implementing a child TPA protocol. First, the ethics of treating a child with this potentially risky therapy. TPA is great, but a lot goes wrong as well, and so this can cause this being implemented in a child to have a lot of questions, such as symptomatic intracerebral hemorrhage after treatment of ICA. There's also differences in hemostatic between adults and children. They've looked at in vitro data looking at clots in mice and found that loosely woven fibrin structures in the final thymos are actually more loosely woven in children than in adults, which would theoretically say that TPA could be more helpful in children or adults. There's actually no data also showing what kind of dosing we would use. And how do we monitor the neuroimaging after the initial and follow-up scans? In adults, there's not a lot of imaging, or if you do, it's a head CT. Implementing an MRI and trying to limit radiation is going to be really important in these younger children. In 2015, a TIP study of the thrombolysis in pediatric stroke tried to answer this question. It wanted to establish a system for evaluation and care of a child with stroke. The preliminary aim is what we talked about, and so they tried to look and see in kids 2 through 18 within 4.5 hours of stroke and diagnosed on MRI, what is the best safety data, dose data, and feasibility? Also, what are the pharmacokinetics in TPA in children after a 90-day clinical outcome? Unfortunately, the study was closed due to low enrollment because it did not happen as much as you think. So in the absence of clinical trial data, the current consensus right now is that when TPA is considered in a child, adult dose of 0.9 milligram per kilogram can be used. This is thought to be conservative dose, but still we're just applying adult data into this. There are obviously exclusions criteria for intravenous TPA, which we've listed here, and those are essentially all the same. I will note and say that an important thing in these scenarios is that, and it really depends on institution, is that for some 13 years and older consider TPA. Anything under 13, no TPA should ever be considered just based on their age. The other one is endovascular stroke treatment. So this has been really cool and really life-changing for a lot of adult patients with the DAWN and Diffuse 3, essentially showing that thrombectomy, even now in an extended window, can remove a clot, restore blood flow, and save brain tissue. But what about children? So right now, the initial concerns are what are the risks and benefits, because they're not established. Right now, again, the consensus opinion through the AHA and ASA in 2015, endovascular thrombectomy can be considered for someone with stroke in less than 18 years old. But there are considerations, right? In smaller kids, smaller arteries. There are also weight-based limitations because if you don't want to give them too much contrast radiation exposure, they're much smaller. In addition, a lot of arteriopathies are the cause of stroke, and they're going to be the ones that are going to be very inflamed. So is it a good idea to go in and try and get the clot with a centrifugal and something that's already stenosed or super inflamed? They looked at 35 cases of recanalization therapy in pediatric stroke, most with successful outcome. However, in general, children recover better from strokes than adults, and a third to a half of patients actually get better without any intervention whatsoever. So this is a little bit what we talked about intensely. Over 13, if it's within the range, 4.5 hours TPA. If it's past that, endovascular treatment's more of a discuss, and basilar artery, it's the same idea, and I get a more of a discuss. So there's no clear guidelines as they have in adults, but it's the best we could do. The hard part is diagnosing the stroke. So EE providers correctly diagnose stroke about 60% of children, giving about 40% of cases with initial stroke mimics. Stroke mimics are tough because these actually happen more common than stroke. You have complicated migraine with aura, you have your Bell's palsies, your post-ictal Todd's paralysis that can happen, as well as something like we call it the stomach flu, but essentially a kid who's been in bed all day, comes up really dizzy. It's really an acute cerebralitis, but how can you rule out something like a posterior fossa or cerebellar stroke? And then you got your other things, your brain tumors, demyelinating disease, encephalitis, traumatic brain injury, intoxication, as well as psychogenic disorders. And there's been just really no clear way to differentiate between the two. I can say that focal deficits happen more commonly in stroke versus stroke mimics. However, I have seen very focal findings in a Todd's paralysis as well as a hemiplegic migraine. And non-localizing symptoms happen in both. So considerations for your future practice is really educate the centers and develop programs of education to improve diagnosis of emergency management of stroke, starting with your pediatricians, ER physicians, EMTs, as well as educating subspecialty providers who take care of these types of high-risk patients, such as cardiologists, hematologists, cardiac intensivists, and really doing more research and seeing if we can understand more, which is challenging because it doesn't happen as often as we think. Right now, there's no clear child studies on acute management of childhood stroke, so it's reasonable to follow the ASA adult stroke guidelines with ICU monitoring glucose very carefully, temperature, seizure management. I think the big thing that we should really caution in these types of cases, avoiding hypotension. So permissive hypertension and looking at MAPs, mean arterial pressures, to really increase cerebral perfusion pressure in these cases is going to be very, very important. Decompressive hand and craniectomy is also an option in these scenarios. There's a lot of questions on why we should do this. Should this only be implemented in centers with pediatric vascular neurologists, which actually there's not many here. Hemicraniectomy management, blood pressure management. There's a lot of knowledge gaps because blood pressures are different in kids, and there needs to be appropriate treatment of hyperglycemia, which can also be different in kids. So this is just a summary of what I said. Essentially, we'll just go through it. You can talk about it later. But I really wanted to get back to our patient because I think this patient is really interesting. So now you guys are all professionals at pediatric stroke. So we're going to learn a little bit more about him. So our previously healthy 4-year-old, which I talked about in the beginning, we learned a little bit more about him. He's unimmunized, has only seen the pediatrician twice in his life. One for a vaccination exemption, and the other one because he just wasn't feeling very well. He's been very tired lately, clinging to mom, but mom thought it was depression because dad passed away about a year ago. The past week, he's been throwing up a lot. He hasn't been feeling very well. He's had a dry cough, tactile fevers. His sister's been sick. So his PMD saw him in clinic for a sick visit, and so he looked so pale and so terrible, they recommended him to the outside hospital ED. There is when we found he had the strokes, and we grabbed some labs. So what you can see is His AST-ALT was very high, as well as his ACFAS. His hemoglobin was 2.4, which they corrected to 5. His INR was 1.9, corrected to 1.4. His CRP was 1.5, procalcitonin was 5.93, and his LDH was an impressive almost 20,000. They did an RVP and found parainfluenza 1 and 3. So in looking at these labs, probably the first thing that stand out to us was that a unifying diagnosis would be that this is a viral infection with liver dysfunction and myelosuppression, like something with parvovirus B19 or something like that. So in talking about infection, viruses can cause stroke. Something like meningitis can cause a vascular stroke in the circle of Willis, or if you're septic, this can lead to embolic strokes due to thrombosis or endocarditis. But what is the role of just a simple common cold in triggering stroke? So we know in adults, studies have demonstrated that minor infections increase the risk of stroke in adults, particularly in young adults. These are case control studies from 1995 to 2000, looking at stroke patients aged 18 to 80 years compared to age-matched controls. And they found that infection within a week before ictus was actually significantly more common among patients with stroke than those with controlled subjects. So in looking at that and testing that hypothesis, the question was why? And the hypothesis really is unclear at this time. It's thought that maybe infection triggers stroke through an activation of inflammatory cytokines, resulting in maybe hypercoagulability, platelet activation as well. Alternative explanations could include using vasoactive cold remedies or mechanical forces of coughing and sneezing might cause a dissection. But in reality, it's probably multifactorial. When you're sick, you're dehydrated and you're not moving a lot either. So this question was asked. Infection happens all the time in kids. I don't know if any of you have kids and remember when they were younger, they're basically wiping their nose and snotty for like the first 6 years of their life. So we're using this idea to understand if there's a potential opportunity for primary stroke prevention, improving hygiene, improving vaccinations as potential avenues for secondary stroke prevention. So to examine this link between childhood infection and stroke, Kaiser did something called the Kaiser Pediatric Stroke Study. And what they did is they looked at all of their pediatric stroke cases from 1993 to 2007 in kids from 29 days to 19 years. And they found 504 childhood strokes. They separated that out into ischemic versus hemorrhagic. And then through the ischemic stroke, they separated it out into non-neonatal versus neonatal. So they had 126 case reports to review or cases to review. And what they did is they had 2 neurologists confirm and pre-establish clinical and radiographic criteria for their stroke. So after the charts were reviewed for each patient, they found to see if there was any recent minor infection in those patients. And that was defined as a documented outpatient medical encounter for an illness within 4 weeks preceding the stroke. Those minor infections could mean something like a common cold, viral illness, otitis media, the stomach flu. And looking at the demographics of these 126 kids, this is the age at the time of stroke. Each bar represents the total percentage of stroke at each age. The light gray shading is used to indicate the percentage of patients that actually had a preceding infection before their stroke. And this lower graph right here, they looked at the month and season at the time of stroke to see if maybe in the winter months, in our pediatric rotations, we were always like, winter is coming because everybody gets sick then, but there seemed to be no association. But you can see that recent acute infection was present in cases of all ages, though more common in children under 3 years old. And looking at multivariate analysis, which showed minor recent infection, this still continuing to remain a strong independent predictor of stroke after adjusting for age in parents of children with chronic disease. So in the Kaiser study, what they did is they looked at visits from physicians, which can underestimate the prevalence of infection. In 2011, they developed the Vascular Effects of Infection in Pediatric Stroke Study, or the VIPS study. And what that is it took a further look at the association between infection and stroke in a large international case control study. It looked at 355 children who had stroke at 37 centers, 5 continents. It's a very international study. So what they did is they had them fill out a questionnaire basically at the time of stroke, as well as throughout the day, or throughout their stroke course for the next 30 days, as well as taking some serum blood samples. They're trying to test the hypothesis, does Does infection transiently increase the risk of stroke in children, regardless of the subtype? So like we talked about, they did reviews within 21 days of the stroke. They looked at serum samples such as herpes, inflammatory markers. They looked at imaging, and they had neurologists look through it all, and neuroradiologists. And what they found first off is that, yes, arteriopathy is probably the most common, with dissection, transient cerebral arteriopathy, Moyamoya. Remainder were non-arteriopathic, so this again confirms what we talked about earlier. Second, which is even more interesting, is that they found that infection within 1 week prior to their stroke conferred a 6.3 increased risk of developing a stroke. So right here, this represents the percentage of children that presented with infection in the prior week, the prior month, and the prior 6 months prior to their stroke. As you can see, stroke cases are in yellow and controls are in orange. You can see that there is a steady increase, and when you suss it out, statistically, you find that after adjusting for infection, this is actually more the case in those in the prior week, but neither infection in the prior month or prior 6 months was actually clinically significant. So with the idea that infection, common cold, can increase your risk of stroke, especially in your young kids, what's the role of vaccination? This has been a hot topic for many years with no vaccination, all of the vaccinations. So it's important and wondering to understand, does vaccination, is that protective against a lot of protective and uses primary stroke prevention against a lot of those childhood illnesses like the flu, VZV, MMR, things like that. So in that questionnaire in this study, what they did is they asked parents, is your child vaccinated? And if so, how good? And we defined patients that were poorly vaccinated as those who answered they only have some of their vaccinations, few of their vaccinations, or none of their vaccinations. And what we found is that children reported to have minimal vaccination had a 7-time increased risk of stroke compared to those receiving all or most of their routine vaccinations. The reasoning behind this is unclear, though. Is it because you're fully vaccinated, you're less likely to get infection? Or if you're vaccinated, this quote-unquote alters your immune system and you become less inflamed, making you less predisposed to more inflammatory reasons for stroke. So with our patient, things that showed up, we did more studies. His CRP jumped from 1.5 to 15.6. We talked about, again, his parainfluenza 1 and 3, which were positive. And they also had a lipoprotein A, which was elevated at the time of initial presentation. So his risk factors for stroke included concurrent parainfluenza infection and elevated lipoprotein, which has been shown to be increased in the setting of inflammation. And then one thing that really stuck out, and I'm sure you guys noticed in the beginning, his hemoglobin was initially 2.4. So they did further studies and found that he had a microcytic anemia. And we weren't quite sure why he had this microcytic anemia, but we were wondering, does iron deficiency, is that also playing a role into why he had such a huge stroke? And the answer is yes. Iron deficiency anemia is associated with all kinds of neurologic problems, breath-holding spells, pseudotumor, cognitive development. And they did a case control study looking at healthy kids from a stroke registry versus control and looked at all these things. And they found that previously healthy kids with stroke were 4 to 10 times more likely to have iron deficiency anemia than healthy children without stroke. Several cases report such an association, but you also have to know sinus venous thrombosis is probably a little bit more common than iron deficiency anemia. The reason why, though, is unclear. Is it because you're now more in a clotty, hypercoagulable state related to your iron deficiency? You have thrombocytosis secondary to iron deficiency anemia, or anemia hypoxia because there's a mismatch with oxygen supply? We're still not quite sure. So for this patient, just like I said, the big things for him, it was multifactorial. There wasn't one cause that caused him to have the stroke. It's usually what I think of as the perfect storm of a bunch of different factors that can cause these scenarios. So for him, unfortunately, no clot retrieval was attempted on the basis of a large stroke volume. There was additional concern for elevated risk for hemorrhage given his unknown cause for recent coagulopathy. After his acute period, he was transferred to inpatient rehab for 1 month and discharged home with a wheelchair. Amazingly enough, after discharge, he started walking on his own, and he just was using the wheelchair for long distances. He developed some strength back on his left side, but more proximal, less distal, and still needed help with a lot of his daily activities, though was learning to feed himself. So that just shows you how well children recover compared to adults, because in adults, this unlikely would happen. So he's followed by neurology still. He's on aspirin, and we're kind of monitoring his MRIs. He's been stable. He also was seen by hematology, and his anemia was initially thought to be secondary to iron deficiency, but it sounds like he's not reticking very well, so they're still kind of working his severe iron deficiency out. So big take-home messages from this is there are a huge range of underlying systemic factors that can contribute to childhood stroke. Sickle cell, cardiac, genetic, trauma, infections, inflammation. Arteriopathy is the most common. Neuroimaging, particularly MRI, is very important, probably the keystone in diagnosis. Minor infection can act as a trigger. Routine vaccinations can be protective. And if you're iron deficient, you actually have maybe a little bit more increased risk of stroke. Okay. All right, thank you.